We continue with the second part of our talk, menstruation and menstrual disorders. And we will see here what happens to the uterus. We discussed the level at the hypothalamic ovarian level, hypothalamic pituitary ovarian level. We discussed the changes that happens in the ovary, and now we'll go into the uterus and see what happens in the uterus. Histologically, the endometrium can best be viewed in two parts: endometrial glands and surrounding tissue. That is the best way to look at it. The human endometrium is organized in two functionally very different layers. The first one is the superficial functionalis, or the functional layer, or superficial functional layer, that appears after puberty and disappears after the menopause, composed of a deeply situated intermediate zone, which we call stratum spongiosum, and a superficial compact zone called stratum compactum. The second layer is the deeper basalis, or the basal layer. This overlies the myometrium immediately. This is present throughout a person's life, all the time. But it does not undergo any significant monthly proliferation, and also it is the source of the endometrial regeneration after each menstrual cycle. Superficial functional layer, deeper basal layer. The classical cyclic changes in the endometrium occur in the functional layer, or the functionalis. So what happens in the menstrual cycle? During the follicular phase, there is a release of FSH from the pituitary gland that leads to the development of the primary ovarian follicle in the ovary. This ovarian follicle produces progesterone. The progesterone, produces estrogen. The estrogen causes the uterine lining to proliferate. At the mid-cycle, which is approximately about day 14, there is an LH surge. That's a response to a preceding estrogen surge. This surge stimulates ovulation, and as we have said, this second stage in the ovarian cycle is ovulation. After ovulation in the ovary starts the luteal phase. Equally after ovulation, what happens in the ovary, the remnants of the follicles left behind in the ovary develop into the corpus luteum, which is responsible for the secretion of progesterone. Ovum being released, ovulation, what is left behind develops into corpus luteum, responsible for the production of progesterone. So what does progesterone do? Progesterone maintains the endometrium lining in preparation to receive a fertilized ovum. So without progesterone, the endometrium lining is sloughed off, leading to menstrual bleeding. Supported has certain growth to support the fertilized ovum for implantation. Fertilization does not occur, the endometrium, the functional layer, will be sloughed off. Endometrial hemostasis. What happens after the layer is being sloughed off? There is bleeding coming from the wall of the uterus, from the functional layer. That bleeding has to be stopped. Hemostasis should take place, and that bleeding within the uterus itself is stopped because of there are platelet segregation, fibrin deposition throughout, and also thrombus formation. Equally, the myometrium contracts, and these contractions of the myometrium are responsible for the period cramps, the pain that the girl gets with the menstruation. So platelet aggregation, fibrin deposition, and thrombus will be formed. This will block the vessels and the bleeding will stop. So the endometrium of the uterus undergoes cyclical changes during the menstrual cycle. These cyclical changes are a response to the cyclical changes in the ovary. During the follicular phase, the endometrium in the proliferative phase will be growing in response to estrogen. Follicular phase in the ovary leads to growth of the proliferative phase in the uterus. During the luteal phase of the ovary, the endometrium enters the secretory phase as it matures and is prepared to support implantation, as we have said. So follicular, with it is the proliferative, luteal, with it is the secretory phase in the uterus. If the ovum is not fertilized, the corpus luteum producing progesterone will degenerate after approximately 14 days, leading to a fall in estrogen and progesterone level both. And as the result, menstruation will take place. The withdrawal of progesterone causes the endometrium to slough, initiating the menstrual phase. And at the same time, FSH levels begin to slowly rise in the absence of the negative feedback from the ovary on the pituitary. The negative feedback will not be there, and accordingly, the pituitary will produce FSH. And thus, the next follicular phase will start. The follicular phase starts again of the next cycle. Only approximately 2/3 of adult women have cycles between 21 to 35 days. Others are outside these ranges. So, in the extremes of reproductive life, let's say early after menarche and in the perimenopausal period, these periods are characterized by a high percentage of anovulatory cycles and or irregular cycles. Anovulatory and irregular, because of the changes that occurs at the ovary and the changes that occurs at the uterus. So you can look here and see the uterine ovarian cycle, very simple. Starting from here, this is a primordial follicle, dividing to give the primary follicle. Primary follicle will go into the secondary follicle. The secondary follicle will mature till it becomes mature here, and then ovulation takes place here, and the ovum will be released ooze out, and at the same time, the yellow body will be there, immature, and then it becomes a mature corpus luteum, which is responsible for the secretion of progesterone. So this is the circle that occurs in the ovary. That acts on the uterus. Earlier on the uterus, you will find that A, here is the myometrium. Nothing is going to change. B is the basal layer. The basal layer, as we have said, does not change, stay there. And the C is the functional layer. And you can see here that there is a growth of the functional layer. Here it reaches this stage whereby there are large vessels, glands, and just 2 days before ovulation, before menstruation, the changes occurs here. This is the premenstrual phase, and then menstruation occurs. So these are the changes that occurs in the uterus. These are the changes in the ovary in response to the pituitary gland. So the proliferative phase, characterized by progressive mitotic growth of the decidua functionalis in response to rising circulating levels of estrogen. So initially, the circulating level of estrogen is rising. That will stimulate the proliferative phase. At the beginning of the proliferative phase, The endometrium is very thin. It's just about 1 to 2 millimeters. But as the proliferative phase progresses, there is evolution of the initially straight, narrow, and short endometrial glands. They become longer, tortuous structures. These are the glands. If you look at this histologically, these proliferating glands have multiple mitotic cells, and their organization changed from low columnar pattern in the early proliferative period to a pseudostratified pattern before ovulation. So these glands change. Throughout this time, the stroma is a dense, compact layer, and vascular structures are infrequently seen. So in the proliferative layer, the vascular structures are there, but not very frequently seen histologically. What happens in the secretory phase? As we have mentioned, ovulation usually about day 14 of a 28-day cycle. Within 48 to 72 hours, 2 to 3 days following ovulation, there is onset of progesterone secretion. That progesterone secretion produces a shift in the histological appearance of the endometrium and changing it into the secretory phase. That is characterized, the secretory phase characterized by clear presence of eosinophilic protein-rich secretory products in the glandular lumen. The lumen of the glands, there is secretion there, eosinophilic protein-rich secretion. Then, in contrast to the proliferative phase, the secretory phase of the menstrual cycle characterized by the cellular effects of progesterone in addition to estrogen. Proliferative estrogen alone, secretory both estrogen and progesterone. So, what happens to the stroma in the secretory phase? The stroma remains unchanged histologically until approximately 7th post-ovulatory day, when there is a progressive increase in edema. So the first 7 days of the secretory phase, the stroma is unchanged. After that, there is an increase in edema. Coincident with that, with this maximal stromal edema in the late secretory phase, the spiral arteries change, as we have said initially, infrequently seen. Here, the spiral arteries become clearly visible, and then they progressively lengthen and coil the arteries during the remainder of the secretory phase. Just 2 days premenstrually, as you have seen in the previous figure, before menses, there is a dramatic increase in the number of polymorphonuclear lymphocytes that migrate from the vascular system. This leukocytic infiltration heralds the collapse of the endometrial stroma and the onset of the menstrual flow. So the vessels change, the lumen of the glandular changes, then there is a polymorphonuclear lymphocyte infiltration, and accordingly, the endometrial stroma will collapse, leading to menstruation. Withdrawal of sex steroids, there is a profound spiral artery vascular spasm. Sex steroid, estrogen, and progesterone. Withdrawn, the immediate thing that occurred to the spiral artery, they go into spasm. The spasm of the spiral arteries will ultimately lead to endometrial ischemia. Also, there is a breakdown of lysosomes and the release of proteolytic enzymes, which further promote local tissue destructions. Spiral artery leading to ischemia, proteolytic enzymes further destroy the endometrium. in the secretory phase. This layer of endometrium is then shed, leaving the decidual basalis as the source of subsequent endometrial growth, as we have mentioned. So, due to the changes in the spiral arteries leading to ischemia, then the lysosomes with enzymes leading to destruction of the stroma and the release of all the functional layer, while the basal layer remains for regeneration of the next cycle. With that, also there is prostaglandin production, and that occurs during the menstrual cycle, but highest as the concentration occurs during the menses itself, highest concentration. What do these prostaglandins do? Prostaglandin F2 alpha is a potent vasoconstrictor, thus causing further arteriolar vasospasm and endometrial ischemia due to the result of the presence of prostaglandin F2 alpha. Also, prostaglandin F2 alpha produces myometrial contractions. These contractions can produce cramps the lady feels or pains, but equally and important that it decreases the local uterine wall blood flow and may serve to expel physically the sloughing endometrial tissue within the uterine cavity. The endometrium will be sloughed. It will be within the uterine cavity. The uterus has to contract to get it out. This contraction is under the effect of prostaglandin F2 alpha. And also prostaglandin F2 alpha produce the menstrual cramps. So we go into menarche. That is the first menstrual cycle. Average age of menstruation between 12 and 13 years of age. And it's usually 2.5 years after the development of the breast buds. In the first part of our talk, we talk about the development of the breasts. Initially, there is a spurt of growth at puberty, followed by breast development, followed by pubic and axillary hair development, followed by menstruation. So from the start of the development of the breast buds till the first menstrual cycle is about 2.5 years. Gonadal estrogen production increases during puberty and thus stimulates endometrial proliferation, ultimately resulting in the start of the menses, the way we have just discussed in the phases that occurs or the changes that occurs in the endometrium. The adolescent menstrual cycle is usually irregular for the first 1 to 2 years after menarche, reflecting anovulatory cycles. So the first 1 to 2 years, the cycle may be irregular due to anovulation. Mothers should not be worried or to be reassured that this is normal for their girls. But on average, it takes about 2 years after menarche before regular ovulatory cycle are achieved. And so if it went beyond 2 years, then there is a problem that has to be looked into and clarified by the treating doctor. Failure to achieve regular menstrual cycle after this period may represent a reproductive disorder. Menarche is usually delayed or often delayed. Gymnasts, girls who play gymnastics, distance runners, and ballet dancers. The cycle or the menarche may be delayed in this group of girls. So the disorders, what happens in the menstruations? We talk about amenorrhea and oligomenorrhea. Amenorrhea means the absence of menstruation. Definition is the absence of menstruation for more than 6 months in the absence of pregnancy in a person of reproductive age. Pregnancy and lactation. So Amenorrhea 6 months in the absence of pregnancy. Amenorrhea could be primary or secondary. Primary is when menstruation has not commenced by 16 years of age. That's primary amenorrhea. Secondary amenorrhea is the absence of menstruation for more than 6 months in a healthy individual of reproductive age that is not due to pregnancy, lactation, or the menopause. So you can see the keywords here: 6 months absence during the reproductive life or reproductive age. This is the second keyword. And the third keyword is the absence of pregnancy, lactation, or the menopause. This we call secondary amenorrhea. Oligomenorrhea, on the other hand, defined as irregular periods at intervals of more than 35 days, probably with only 4 to 9 periods per year. Most of the time, the cycle goes beyond 35 days. That is oligomenorrhea. The menstrual disorders, the one we have just mentioned, and others, could be due to problems either in the hypothalamus, the pituitary, the ovary, or the uterus. You can see starting from the top and going down till the disorders come into the endometrial disorders. The WHO did a quite good classification of the problems that occur with the menstrual cycles leading to anovulation or disturbances. The WHO made the classification to involve the 4 organs I have just mentioned: the hypothalamus, the pituitary, the ovary, and the uterus, which we call the hypothalamic pituitary ovarian axis. They classify the abnormalities into 4 types. Type 1 WHO is hypogonadotrophic hypogonadism, low FSH, low E2, hypo both. Type 2 normogonadotrophic normogonadism, normal FSH, normal E2. Type 3 hypergonadotrophic hypogonadism, high FSH, hypergonadotrophic, but the estrogen is low, low hypogonadism. So these are the 3 relating to the FSH and E2. And the 4th category is hyperprolactinemia, when prolactin is high. So let us look at them briefly. Hypogonadotrophic hypogonadism type 1. As I have mentioned, low FSH, low E2. These could be congenital or acquired. Congenital, the common example we give is Kalman syndrome, low FSH, low E2. The acquired conditions are pituitary tumors, pituitary necrosis, what we call Sheehan syndrome, severe postpartum hemorrhage leading to necrosis of the pituitary, or stress, or excessive weight loss, exercise. And in this situation, what we have to do is to examine the eye for the visual field, because if this is the clinical examination we need to do. If the pituitary tumor, it could affect the visual field. What we confirm the diagnosis with CT and MRI when we are suspecting a space occupying lesion. The second type is normogonadotrophic normogonadism, or type 2, whereby FSH is normal, E2 is normal. The majority of these cases are due to polycystic ovary syndrome, PCOS. And we'll see in a minute what do we mean by polycystic ovary syndrome. Other possible causes are congenital adrenal hyperplasia or adrenal tumors, androgen-producing ovarian tumors are the possible causes of hypogonadotrophic, of normogonadotrophic normogonadism. Normal FSH, normal E2. PCOS, congenital adrenal hyperplasia, adrenal tumors, and androgen-producing ovarian tumors. We go to the third type, hypergonadotrophic hypogonadism. High FSH, low E2. Seaton-Turner syndrome or Turner mosaic. Also, we see it in premature ovarian failure. High FSH, low E2. Autoimmune or iatrogenic in cases of irradiation, chemotherapy, or surgery. Irradiation, chemotherapy, and surgery. All these could lead to type 3 WHO classification, hypergonadotrophic hypogonadism. The fourth category is hyperprolactinemia, high prolactin. What does high prolactin do? It usually interferes with the pulsatile fashion of GnRH release. We know that GnRH released from the hypothalamus in a pulsatile up and down fashion. Prolactin or hyperprolactin interferes with this pattern and thus leads to anovulation, amenorrhea, and occasionally galactorrhea, milk coming from the breast without pregnancy or lactation. Possible causes of this hyperprolactinemia are pituitary adenoma. Pituitary microadenoma is a common cause of hyperprolactinemia. Primary hypothyroidism, chronic renal failure, drugs which are combined oral contraceptive pill or dopamine depleting agents. They deplete the dopamine. These are examples of them as reserpine, methyl dopa, drugs we use to treat the hypertension. Or the third category of drugs, dopamine receptor inhibiting agents, inhibit the action on the receptors. These are metoclopramide and phenothiazine groups. So having known this picture, then we will classify the disorders that occurs with the menstrual cycles, oligomenorrhea, amenorrhea, other dysfunctional uterine bleeding, which we call it now abnormal uterine bleeding, is another topic we can talk about later on. Then after that, we come to see them, how the WHO classified them, put them into simple 4 groups: hypogonadotrophic hypogonadism, normogonadotrophic normogonadism, hypergonadotrophic hypogonadism, and hyperprolactinemia. And as we have mentioned, the one commonly seen in cases of normogonadotrophic normogonadism is polycystic ovary syndrome. I'm sure we will have a proper lecture on what is polycystic ovary syndrome. But as we do ultrasound in young girls, in a lot of them, we found small cysts on the ovary, to the extent that the sonologist or the radiologist will tell the lady that, or the girl, that she had ovarian cyst and may refer her to the gynecologist. But not every ovarian cyst is polycystic ovary disease or syndrome. There could be so many follicles, so many cysts, but it is not the syndrome. The syndrome is usually diagnosed by the Rotterdam criteria in the ESHRE meeting. They put it as follows. If there are two of the following three are present, and these are the following three. One of them, disturbance of the menstrual cycle, either the oligomenorrhea or amenorrhea. The second is clinical or biochemical signs of high androgen levels. High androgen levels, clinically, you can see them by acne on the face, hirsutism, excessive hair, alopecia, baldness. These are the clinical, you can see it in the girls. Chemical, high free testosterone index, or high dehydroepiandrosterone sulfate. The polycystic, the third criteria is by ultrasound. So clinically, disturbance of the cycle, biochemically or clinical signs of high level of androgens, and the ultrasound findings. Any two of these will diagnose polycystic ovary syndrome. And we say, if you are doing the ultrasound, about 12 cysts, each measuring about 2 to 9 millimeters in periphery of each ovary, or the ovarian volume is about 10 milliliters. So this is how to diagnose the PCOS. And I brought the picture or the information here that not every polycystic ovary is the syndrome. It could be to so many other physiological probably causes. This is the ultrasound way, the ultrasound of the polycystic ovary. You can see here, this is the ovary. This is the cortex. These are the cysts, small cysts around in the cortex. The medulla here is free, no cyst or very minimal. And as we have said, to be about 9 to 12 or a volume of 10 mm. So by ultrasound or chemical or clinical or amenorrhea or oligomenorrhea, we can diagnose polycystic ovary syndrome. You will have more about it during your lectures. And I think we stop here. This is our last lecture and the completion of the second part of the menstruation and menstrual disorders. So we stop here.